do have our director of our cath lab is a woman, so there's not there are women in the cath lab, ladies and gentlemen. Dr. Kitty, you see her all the way to the left, and we see the two operators, Dr. Dangus in the middle.
Yes.
And I think that we have Dr. Joseph.
We have two fellows.
Our two fellows.
Yeah.
Okay, Dr. Kitty, you're on.
Okay. Good morning, everybody, and welcome to New York. We have heard the great lecture which Dr. Mehran was giving so far. So we have this 58-year-old lady who actually presented a month ago to another hospital with the non-Q-wave MI, and at that time she had a disease of the circumflex which was intervened. I think post-procedure she did very well, but she had a brief episode of atrial fibrillation, but was not started on any anticoagulation. We can discuss when we should start anticoagulation on these patients for paroxysmal AFib in the setting of coronary artery disease. And this is where we are. You see that her left side, the circ looks very good, and LAD actually is non-obstructive.
So because I just want to kind of go through this with our audience, maybe you can lay out and give us a very good didactic of the anatomy of what they're looking at.
Good.
This is
this is the left side. In the cranial picture, if you see there,
the left coronary artery.
Just as soon as the dye comes out, you see left main, and the left main will then bifurcate into the main artery, which is the LAD, goes all the way to the apex. The branches that come out of the left main, LAD, are the diagonals, which you can see, and anything that is caudal, which is you see here, you see the circumflex and the branches. Yeah.
So 1 minute, let me just show the audience. This is the left main. You see the left anterior descending, the most important artery of the heart, coming all the way down into the heart. This is the whole heart here. And this is the circumflex artery. Can you play it so we can see this? It's now empty.
You can see the stents third. They're going to be filled slowly and widely patent.
Yeah, so we have previous stents in these arteries. Here it is in the circumflex. You see that kind of a flush before the dye goes in. We know there's a stent in this artery. This is the circumflex. The left anterior descending is here. I'm still not clear if we're clear of lesions. On the panel here we have Dr. Gennaro Giustino and Bimmer Clausen, two of your of trainees.
In the meantime,
Dr.
you can
Dangus
see a
and Dr.
normal
Kinney.
LV ejection fraction in
This
this view.
is the left ventricle. You see how nicely it's squeezing. That's the heart. And this is the right coronary artery.
So I think this is where we can have a discussion. So in this patient, what actually happened, so she does have significant disease of the proximal RCA. So proximal RCA is part of the RCA just after the guide up to the first RV marginal. Then there is moderate disease, about 60-70% after the RV branch. You can see in this view also.
You can see in this view very eccentric in the middle of the RCA. You can see that at the middle of the screen around like maybe 9 o'clock.
So we have a long 80 millimeter lesion in this patient. So she was sent home on a medical therapy which included aspirin, Plavix, then she got the Lipitor as well as beta blocker. Because it was first time they did not give a second anti-anginal, but now then she saw her cardiologist, she has symptoms that's ongoing, she was referred to us for further management. So you saw the left side, it looks good. So now since in between she did not have any stress test as an indication that does this right coronary artery cause her symptom? Or the question also comes is, can we manage the right coronary artery disease just on medical therapy? Can we add another anti-anginal and keep her on medical therapy rather than doing more stents on this patient? So what the guidelines suggest?
Especially if you're contemplating starting this patient on an oral anticoagulant, the more stents you put in, the more dual antiplatelet therapies you need. But if you actually could get away from if that right coronary, even though there looks like there's a blockage, can be managed medically with anti-anginals, and it's not a life-threatening lesion with the ischemia producing, can you get away with it so not have to give an oral, when you give an oral anticoagulant, you could be more safer, less dual antiplatelet therapies. So you're doing I'm trying to understand what you're doing.
Okay, 1 second. We have performed already the diagnostic test regarding the blood flow inside the arteries, and we put a FFR pressure wire into the distal RCA.
Exactly.
We gave IV adenosine, and beyond the distal RCA position, the value was very quickly down to 0.75, which was highly significant. We're going to show it to you.
No.
And then we performed the pullback assessment, and in between the two lesions, the FFR increased to 0.80, still significant, and in the very proximal lesion, at the guide level, it was normalized by the pullback. So therefore, we assessed that both lesions are critically significant by the FFR being highly significant distally, and by the pullback being highly significant and normalized only when the guide went. So the bottom part was 0.75, the middle part was 0.80, and the normally was over 0.95 in the very proximal. You can explain what this means in the audience.
Yeah, so the fractional flow reserve is an important indicator of understanding using a response to hyperemic response, whether or not there's an important gradient across these lesions. And when you have serial lesions, two lesions in the same artery, you want to see which one is important. And so what they did is they gave adenosine intravenously to create a hyperemic response, and then measured the pressure, and you saw the differential between the intracoronary, the proximal to the distal pressure gradient, and you saw that there was a significant difference. Anything less than a 0.8 is significant, and there's enough data to show that these patients who have a 0.8 and less should undergo a PCI. It's indicated to do that, and that's exactly what they did. So the next step here is now they made a decision that these lesions are ischemia producing. There's ischemia production. There is a lot of ischemia in that right coronary artery, so they need to stent that. Now, in order to optimize their stent implantation, especially if they're going to go to a dual therapy, as we discussed today, if they are going to start oral anticoagulants, is I'm seeing that they're imaging inside of the artery, intravascular ultrasound. So that's what this is. They're pulling back inside of the artery, going through from distal all the way up to the proximal. And what you're seeing here on the screen is the artery, the right coronary artery that we just saw. Because the angiogram is a two-dimensional figure, whereas the intravascular ultrasound gives you a great way of measuring the vessel size, the lesion length, and understanding the plaque burden. Are there any comments from Dimmer and Gennaro? Maybe you can tell us, Dr. Klassen and Dr. Justino.
We just want to show you how calcium or normal plaque looks under IVUS. So let's go to the right here. Stop here. So you see that bright area which is 3 o'clock to 6 o'clock. That is, you can see that calcified fibrous plaque. Not a lot of calcium, but calcified fibrous plaque. The reason I am saying it's a calcified fibrous plaque because you can still see the vessel behind. If it is true calcium, you will not be able to see anything behind. Now there's a nice demarcation that you see also. That is also little calcium. Now, why did we do both the studies? Why did we do both the studies, FFR as well as IVUS? So angiographically, if you look at it, you do see mild calcium. But when you see mild calcium in a vessel like this long lesion, you should always consider. Now here this is calcium. Go back. This is nice. You see that? You don't see a lot of the vessel behind.
About 150-degree arc between like maybe 2 o'clock and like 6.5 o'clock at most.
And all the studies and guidelines say that if you are doing to understand calcium or no, you got to do intravascular ultrasound or optical coherence tomography to assess the calcium. And what is the guideline is that anything 180 degree. So that is the arc. 180 degree or more becomes severe, less than 180 degree you can say moderate calcium. So, when it is moderate calcium you can consider PTCA and or atherectomy with, we will show you couple of devices that we are going to use. If it is severe calcium, you got to consider atherectomy, which is a rotational atherectomy or orbital atherectomy, and that is the reason we did IVUS. So, we can show you what device we are going to use and the reason for using this particular device. So, based on the calcium that we have seen, we are just going to do balloon angioplasty now.
Yeah, so really important to understand what's going on here. What we call this is precision PCI. PCI is not just, oh, go in, put a balloon in and put a stent. You're seeing we are precisely evaluating whether or not that patient is ischemic with that pressure wire that we just did, the FFR. Then when we said, okay, now we need to do PCI, we want to make sure we do the right thing. The first thing is the intravascular ultrasound gives you the vessel size, plaque morphology, very, very important. And as you just heard Dr. Kinney say, that the plaque morphology here for her would make a difference on how she would choose which device. If there is a very calcific vessel that you're not going to be able to expand before you put your stent in, and you didn't do atherectomy, you're going to get a bad result. So she now found with that intravascular ultrasound that she doesn't need to do the rotational atherectomy or a really, really big procedure that grinds the calcium before you put the stent in or breaks up the calcium. Instead, she's going to use, she saw a fibrocalcific vessel in which she can use interesting technology to still break the plaque. It's strong enough to break the plaque and still be able to get a very good result with the stent. Does that make sense to everybody now, why she did this? Okay, so tell us what you're doing here. You see what was the device.
So,
and
this
what
is
you're
a
doing.
high pressure balloon, 27530 long, 27530 balloon. We did 2 inflation up to 18 atmosphere, and more important, you see that is a nice expansion. So, that is the key, that you need to do good plaque modification once you know there is calcium. So, we did good expansion of the plaque, and right now we will do an angiogram again. If it looks good, we are going to be ready with the stent.
By the way, we're using an Angiomax bilirubin here for the anticoagulation, a very high ACT over 300 as appropriate. And yeah, and we check the PRU
Can you just keep that
for the
plain
Plaque,
so we can show?
and it's 133. So the patient is highly sensitive to plaques.
Okay, can you just show us what you're doing right now? Can you play the angiogram and leave it open? Because I want to show the pre and the post angioplasty results. So the intravascular ultrasound helped us evaluate how much stenting is going to happen. Show us what your plan is, but you see here, the blocked artery looks much more better. The artery looks almost normal looking. This hasn't even been touched, and it looks basically the same as up here. But inside of the vessel, the calcium and the plaque has been disrupted with balloon angioplasty. There needs to be a stent there to keep that vessel open. You can't just walk away by looking at this angiogram and saying, oh, it looks good, I can be stopping. I don't have to put a stent in. We know very well that this artery will close if you don't put a stent in. So tell us what you plan to, maybe you can show it with your, do you have a marker of how far the stent is going to go, how long the stent is going to be? And what the IVUS showed on where you have to cover it, the lesion?
So, if you see the distal edge of the IVUS where we started, there was barely, we show the distal edge of the IVUS there, distal, go back.
No, on angiogram. So the angio where you put the
So
IVUS.
this is where we are post-op. We're going to go from normal to normal.
So it looks like they're going to probably stent this entire area because the IVUS
Yeah, so
really,
the distal edge of the IVUS, if you see there,
yeah, we
no
saw
plaque.
the IVUS. The IVUS is, shows that there's plaque everywhere. If you keep that on, show us the plaque. Okay, show us the plaque with the IVUS, the worst plaque.
Yeah.
Look at that here.
By
You can
iris, the
see-
distal vessel was 3.0 in reference diameter and the proximal 3.5. So that's a basic size of the stent. And then we're going to have to go 2 long stents.
Go back to the plaque, please. Yeah, here we go. So you see here, the lumen, you know, the vessel, the lumen is really small. It's hugging the catheter. That's how big that lumen is. And this is the vessel. The vessel itself is all the way out here. The lumen is here. All of this is plaque, ladies and gentlemen. All of this is arterial plaque. So they already ballooned this, and now they're going to put a stent and expand it to this, like a cage to keep this open. Okay, so show us what you're doing. And you see here, they went all the way, that's where they started their imaging, all the way from here, all the way to the, this is your first stent?
See, 28.
32, I'll probably go. Let's see where we are here.
And you see they're using their markers to measure
No, too long.
the stent
28.
length.
28.
3.0.
3.0, 3.5. 3.0, 28. On a post deal with 3.5.
Yeah, nice. Now the vessel has plumped up and looks
Sure
good.
it's not 32?
You see how much bigger the
Final
vessel
call.
looks?
You want 30?
Can you all
32.
appreciate that in the audience? It's a whole different vessel. It's a big, big
32 you
vessel.
want.
We got to keep this vessel open. This is what
Overlap a
we
little bit, yeah.
we just did this, and we want to make sure it stays open. And we know that in order to prevent the stent from thrombosis, dual antiplatelet therapies work best, better than oral anticoagulants.
It's good. It's
And in a
good that
patient like this,
patient
we have to make an important
is
decision.
tested, sensitive to clopidogrel, so this way we can plan better from now on what to do. Perhaps we can discuss a little bit this plan as we put in the second stent in.
Yeah,
You
it's
can
great
carry on this
actually to kinda
discussion
have
with the
this
experts,
discussion.
Dr. Gennaro and
So,
Klassen.
Dr.
No,
Halpern is
Usman,
actually here in the audience. This is a patient who presented with an acute coronary syndrome who then had paroxysmal AF and has coronary disease, 2-vessel coronary disease. The circ was stented, and you see the stent length they're putting into the right coronary. Paroxysmal AF, now in sinus rhythm. CADVAC, I think it's 3.5. But is in sinus rhythm at this time. So our big question and dilemma after this stent is placed is to say, what do we do for this patient? Can we ask you to come up for a minute so you could comment? And maybe our colleagues here, what would they do? And then we'll ask the master what he's going to do. So you guys, our junior folks will tell us what they would do. Gennaro, how would you address a patient like this?
I think thromboembolic risk should be considered here, so I probably would anticoagulate this patient with a NOAC and having a P12 inhibitor on board.
Remmer?
I think I would continue with dual antiplatelet therapy and consider the atrial fibrillation as being as part of the ACS and just go with dual.
So very interesting, right? Two physicians, two different answers. One believes that the acute coronary syndrome was the reason for the atrial fibrillation. Does that put that patient at less of a risk for a stroke? And so we couldn't just go with a dual antiplatelet therapy. But Gennaro, Dr. Justino, says, well, you know what? Non-sustained paroxysmal AF in that patient with coronary disease puts that patient at a high CAD-VAS score. And I'm worried about stroke, and I want to prevent stroke. So let's ask the master, Dr. Halpern, what should we do? It's the usual question.
So you should certainly realize, first of all, I'm a techno peasant. They don't allow me to touch any sharp objects at Mount Sinai. I would only make them. So they keep me as far away from these stents and cath labs as possible. Let me just ask one question. This patient had no prior history of atrial fibrillation before the acute coronary syndrome that we know of?
Yeah. Dr. Kinney, do you know the answer to that? Did this patient have any history of atrial fibrillation before the acute coronary syndrome?
That we don't have because she never
she
visited
did
the
have-
doctors.
And also she didn't have real symptoms there, so she may be having it subclinical.
Yeah.
So this is a first detected episode of atrial fibrillation in the setting of an acute coronary syndrome. And that's the way we never know really when atrial fibrillation begins, but we know when we first find out about it. So I would suggest that this could be all due to the acute coronary syndrome. I would not rush to re-anticoagulate this patient. I think dual antiplatelet therapy is the requirement early on, and then a decision will be made based on whether or not there is recurrent atrial fibrillation. Let me just point out one or two things. Number one, atrial fibrillation in the setting of an acute coronary syndrome is among the worst prognostic signs. It's an arrhythmia of pump failure, and it points to the importance of opening this artery. This patient really was threatened by the occlusion of this vessel. Secondly, the CHADS-VASC score, the CHADS score, it was not derived from patients with acute coronary disease. So we should be careful not to extrapolate the risk profile from a stable population of patients with atrial fibrillation into this situation. I think first we have to find out whether this patient will prove to be a recurrent fibrillator. Secondly, we need to take a fresh look at the risk of thromboembolism. And my guess is that that risk will be no more than modest, in the order of, say, 4% per year. 4% per year is a lot. If you divide that by 365, is a very low risk on a day-by-day basis. The greatest immediate risk is for stent thrombosis and recurrent myocardial ischemia or infarction. Dual antiplatelet therapy now with a potent combination like ticagrelor and aspirin, and then reassess for recurrence of the arrhythmia.
So how would you do that, the reassessment? Are you
So
going to
we
put this
begin-
patient on a Holter or a
begin with
monitor?
short-term monitoring. If you put a Holter monitor on, or a 1 week or even up to a 3-week event monitor. If you're not sure, we have implantable loop recorders. Today we have smartphone-based devices, or Apple Watches and other ways that we can survey patients for atrial fibrillation. But I'd like to see a recurrence of atrial fibrillation before committing this patient to a combination of an anticoagulant and a platelet inhibitor.
Wonderful. So this is, as you can see, there are a lot of different opinions, and I think that what you're hearing from Dr. Halprin is that at the moment, the risk of the acute coronary syndrome could have been the nidus for the atrial fibrillation rather than inherent atrial fibrillation.
Stenting. Pulling back.
What now they're doing is putting that
Distal edge,
intravascular
great
ultrasound
transition.
back in
No
the
dissection.
vessel, and you start to see the stent. You see the demarcation of the stent? That was a beautiful transition from the distal to the proximal vessel. That lumen, remember, was here. Now it's been pushed back against the vessel wall with a really good adherent, well-expanded stent. Let me see if it's well-expanded all the way through.
All the way. Is at least
nicely
3
well
to
I don't know. You could go a little bit more, I think. How far? How much did you
all the way
expand?
to the back. So what we actually did
We're
was,
in the middle, the 2 lesions already covered and the perfect circularity. Now we have one more final lesion in the more proximal. So far, perfect circularity, which has been a predictor of great outcome if the stent is round versus elliptical. And this is round all the way.
This is where that calcium was that Dr. Kinney was showing you.
I think
the
what
stent-
is the same thing. If you see calcium, you got to make sure that your post stent is well expanded. If you have an underexpanded, unopposed stent, there's a risk of stent thrombosis with this long stent.
And coming up to the transition proximally, great transition, no dissection.
Yeah.
Okay.
No dissection. And it also shows you, sometimes you can't see these dissections, small little tears in the vessel at the edges of the stent on the angiogram, but you see it very, very well. The ultrasound really, really kind of stamps your precision of how well you expanded and put this stent forth. So any comments from Dr. Any of you guys have any comments about the intravascular ultrasound, the results, etc.?
I think this is a really good application of using IVUS. I think you shouldn't be using this in every case, but research from my colleague, Justino, has shown that in the more complex cases like this one, where there's a lot of stents implanted, very long, then there's some calcium there. That's the type of patient that will really benefit from optimized stent implantation.
That's a very interesting concept. It was first started, I think, from Dr. Colombo in 1995, when once upon a time all patients were getting Coumadin after a stent, and he showed that with the use of IVUS and optimal stent implantation, actually you could avoid that and use an antiplatelet regimen instead, and having a lower rate of stent thrombosis. So intravascular imaging and optimizing the procedure actually impacts on then pharmacologic decision that we can have.
Yeah, very, very important that we feel very confident about the stent apposition, how it's opposed to the wall, its expansion, its form, and you can see here in the angiogram that Dr. Kinney and Dr. Dangus just performed, this stent, the artery is widely patent. Can you just show us both of your views again, Dr. Dangus, Dr. Kinney?
The final picture.
Look at that. The wire's out. The arteries looks like brand
Wire is
new,
out.
normal. Yeah. Very good. And they look at both views, this view, and they want to go to another view to make sure that everything is intact. All the branches are still there. These are all important things that we look for during a PCI procedure. Are there any questions from you? You have a great opportunity to ask a question about a percutaneous coronary intervention here with our operators. Any questions? Please feel free. Don't be shy. I know they look like they're smarter, but they're not. Any questions? Yes, please. 1 second. We're gonna get you a mic. There's a question from the audience, Dr. Dangus, Dr. Kinney.
Yeah, we like questions.
Go ahead.
So hi, it's Joanne Trainer from the Philadelphia area. What is the risk of stroke as you modify this calcium, either using the balloon angioplasty and after stenting, just from disrupting all that calcium?
Oh, very good question. What's the risk of stroke, thromboembolic stroke from a percutaneous coronary intervention? Because you're doing a lot of plaque disruption inside of the artery. Does any of that plaque go up to the brain, Dr. Kinney, Dr. Dangus?
Very interesting question. I mean, once we are doing all this work, you see that since the blood flow is also going down, antegrade, most often when we are doing anything with the calcium, you see problem in the distal bed, not usually, not retrograde where it flies up to the brain. When do you see that it could likely fly to the brain? If you have a lot of atheromatous debris in the aorta, and when we are going with the catheters across the aortic arch, that's the time that anything in the aortic arch may fly up to the brain. That's number one. Number two, what studies have shown that when we are doing ostial disease, this is not the ostial means you are close to the aorta and the artery is originating. That is where if you are working around there, or more importantly if you are doing vein graft intervention, which is lot of thrombus, and you are doing some kind of a suction, that has been shown likely that kind of a suction which is thrombus could embolize to the brain, but not the kind of work we just did. The kind of work we just did will cause what we call as a slow flow, because the debris go downstream into the vascular bed below.
That was a really good question, and actually the incidence of post-PCI stroke is quite low. Very, very low, 0.1%, even lower. And it's all related to the catheter manipulation rather than the work in the coronary artery. And I think that's what Dr. Kinney is alluding to. Dr. Halpern, you have any further?
No, I agree. I think it's the disease of the aortic arch that is the main threat to stroke when catheter manipulation is performed in the coronary arteries. The concern here is distal embolization into the coronary circulation itself rather than retrograde into the brain.
Great. Any other questions? Yeah, we have another question in the back of the room. Can you guys stick with us? I know you were closing the artery. We're going to show us that too. How you close the artery. Yes.
Arrange manual removal later on.
Yeah.
Annie Harrington, I'm from Texas. So my question is, if a patient in the next 30 days develops a stent thrombosis, what happens?
So the couple of things we have made sure. So we did IVUS. Okay, we made sure the risk factors for stent thrombosis are very clear. Somebody which she has, but she has passed 30 days after ACS, they have risk of stent thrombosis. Long stent, which is more than 60 millimeters, she has right now. EF, where that is less than 30%, which she does not have. Other than that, any risk that she will be that kind of antiplatelet therapy that she'll be going home. That's why we checked a PRU. Ideally, if a patient presented with a non-STEMI ACS, they should be, as the studies have shown, on the stronger, newer P2Y12 inhibitors, which she was not on. Instead, she was on Plavix. We checked the PRU. PRU right now, which is a platelet reactive unit, is 133. Anything less than 230 means that the platelet are well inhibited. So, if the platelets are well inhibited and our IVUS shows the stent is well expanded, so the risk of stent thrombosis is less than 0.1% for her.
Very low risk, because you
Unless
have the circular stent with a very good MLA above 7 and with the PRU under 133 on steady state Plavix, not in an effect of some kind of a loading or stuff like that. This was the steady state Plavix. She's been taken for a long time. So therefore, this patient is very well protected based on what we can score. And you know, of course, diabetics, calcific lesions, and other aspects we discussed, she doesn't seem to have. So that's, I think, very low risk.
Well, so as Dr. Dangus and Dr. Kinney alluded to, she does have, the first 30 days are the most vulnerable time. She does have a risk of stent thrombosis more than a patient who came for an elective PCI, because she presented with an acute coronary syndrome. It's important because we put a lot of stents, a lot of metal in this artery, in a small artery. Again, another risk, but they minimized and mitigated these risks by using intravascular ultrasound, making sure they got a great result, and then measuring the platelet inhibition on clopidogrel to make sure that she has a very, very good steady state of paralyzed platelets, which is what they showed with their platelet reactive units. I hope that makes sense to all of you. Another last question before we go to lunch and we close out the cath lab.
Very good. Excellent.
1 second. One more question. One more question.
Also, what time is lunch over? Because I have a talk right after lunch.
1 o'clock.
Just since we were talking about comorbidities and such, is there anything you can tell us about this patient's history? I mean, she's 58 years old. She has severe coronary artery disease. Anything else relevant to the whole picture of the patient?
Yeah, so 58 years old. We see coronary disease. What other risk factors does she have, and what other things we have to worry about in this patient, Dr. Kinney?
Yeah, so one, she's a woman postmenopausal. Number two, she has been a smoker all her life and strong family history. I think with these three risk factors, she, metabolic syndrome, in the sense she's diabetes
under
a diet controlled. With hemoglobin A1C about 5.7, so we can say that it's not true diabetes, but she's metabolic syndrome that they say.
Yeah.
But I think with the three, which is family history, smoking, postmenopausal woman, that were the risk factors for her. So the key thing is the same. Now that we've taken care of the so-called obstructive lesion, how do you prevent progression of the non-obstructive disease that she has, which is less than 30% elsewhere, is lifestyle modification, which she has done. She has stopped smoking since her MI. And right now she's following up with the patient. She has been started on a statin, and she's following a heart healthy diet and exercise.
And she's going to come to your yoga classes, Dr. Kinney?
Yes.
Yoga. Well, with that, we want to really, really thank the staff at the cath lab, Mount Sinai Cath Lab, as well as Dr. Kinney, and there they are,
RP,
all of them.
Look at the entire staff.
Everybody.
It's not just about the operators, it's the entire staff and the team that has been built there at Mount Sinai under the direction of Dr. Kinney as the director.
The dream team here. Why do you go on and on?
Thank you, Pablo, for getting that patient on the thing. And at the end, we have a happy patient with the patent artery, happy staff, and the patients are happy, and so are we. And hopefully we get a great result. Thank you so much for this, and we see you here. Dr. Kinney, please come and see us here and meet everybody.
Yes.
Everybody would love to meet you. Thank you.
We'll be there. Thank you.